Second. Right, so good evening, everyone. Thanks for joining us again this month. So this evening we've got our third bare bones session on elbow. So we've got some great talks. Ollie and Kriti are going to talk to you about some elbow anatomy and some trauma. So I'll hand you over to Ollie, who's going to talk to you about some anatomy up first.
Thank you. So can I share my screen now, George? Yeah. Great. So can you hear me and can you see that screen? Excellent. Right, welcome everyone. My name's Ollie. I'm one of the committee members, one of the treasurer for the BOTA committee. I'm also a registrar down in Bristol. So it's going to be a 15-minute crash course on elbow anatomy. There's a hell of a lot to cover, but the important thing is this is going to be recorded. So the idea of these slides will be able to provide you, hopefully, useful information so you can watch it in your own time. We're going to be running over the osseous anatomy, so the bony anatomy of the distal humerus and the elbow joint, the muscles surrounding the elbow joint, particularly the ones that are crossing it, the relevant nerves of the upper limb with points of entrapment and some clinical application for when you're examining these patients. And just a brief introduction to imaging of the elbow and potentially some pitfalls. We're not going to be covering pediatric elbow anatomy or brachial plexus today, but a lot of the content will have clinical applications of the surgical reference, which I hope you will find useful. So if we start off with the bony anatomy to the elbow, so we have the medial epicondyle on the inside, lateral epicondyle on the outside, capitellum, which articulates with the radial head, and the trochlear, which articulates with the ulnar. So as we swing across, as we show, you can see how the three bones will articulate with each other. We have the medial epicondyle there and the olecranon there and coming around the back. And you can see the Electron Fossa where the Electron process sits in. And as we swing around more, you can just see here the proximal radial ulnar joint and the radial head articulating with the trochlear. That's the proximal radial ulnar joint there. Swing around again, we'll remove the humerus and you can just see the intricate sort of relationship with the radial head sitting in that sigmoid notch or the ulnar notch of the proximal ulnar, allowing for the pronation and supination of the elbow joint. Finally, the important little bony process called the coronoid process, which provides a lot of stability to the elbow. There are two hollows of the distal humerus. You've got the coronoid fossa on the front and the Electron Fossa at the back. And this allows for the coronoid process to sit in and the Electron process to sit in. Now, this has particular relevant context of supracondylars. You can see how the two fossa merge, providing a tiny wafer, a really thin margin of bone. So when you have the hyperlax kids, and when they fall on an outstretched arm with the elbow extended, it pinches within this wafer of bone, and then you lead to this type of distal humeral or supracondylar fracture. And I know Kriti is going to go into that in more detail. And then the bony anatomy provides some justification of where we put our K-wires or our wires to fix these injuries. And we're going through the areas where there is most bone. So we've got the medial column and then the lateral column. And not to forget the ulnar nerve that runs right behind that and can be prone to injury when we're doing these surgical procedures. We'll look at the stability of the elbow joint. So there are two types of stabilizers. You've got the static stabilizers that forms part, well, they are formed by the bones, the joints, the ligaments, and the soft tissue. And then you have dynamic stabilizers of the elbow joint, and they tend to be the muscles that cross it. So as we look at this now, we can see that the highlighted area is the capsule in green. And as we swing around to the ulnar side, you've got the ulnar collateral ligament or the medial collateral ligaments, which is a broad sheet of connective tissue. And that provides your valgus constraint. And then as we swing around all the way to the medial side, you've got the medial collateral ligaments or the radial collateral ligaments, which form two bands. One inserts onto the distal ulnar, proximal ulnar, sorry, and one inserts on your annular ligament and the radial head. And that brings us onto the annular ligament, which is highlighted here, coming in green. And that sloops around the radial head and helps to protect, so keep that radial head right in close proximity to the ulnar, and helps to articulate with the proximal radial ulnar joint. Stabilizers are particularly helpful to understand when it comes to treating these types of injuries, the Tilbrook Triad. So that is a case of, that is an injury which is associated with 3 components. You've got the soft tissue ligament component of the lateral collateral ligament, and 2 bony components, your radial head and your coronoid process. So therefore, when you lose the integrity of those 3 components, you have a very unstable elbow dislocation, or even a complex elbow dislocation, rather than just your simple elbow dislocation, which is purely ligamentous. And Kriti will go into that in a bit more detail. But then that just explains why we put all the pieces together and fix them in place with the plate and screws, and repairing the ligament to provide that bony or your static stability of your elbow joint. We'll look at the muscles now, and ones that cross the elbow. So we'll start off with the biceps. The biceps has 2 heads. You've got the long head that inserts onto the supraglenoid tubercle, and then your short head, which inserts onto your coracoid process, not your coronoid, but your coracoid process. And as you come down towards the elbow, these merge onto the biceps tendon. And as you finish with your biceps tendon, this is where they insert onto the footprint, which is your radial tuberosity. The biceps is supplied by the muscular cutaneous nerve. We'll move on to the next flexor, brachialis, slightly less exciting, but that just crosses the elbow, inserting onto the proximal ulnar, and it's a single head, and this is supplied by the muscular cutaneous nerve. And finally, the brachioradialis, which tends to be more of a forearm muscle, but does cross the elbow, originating from your supracondylar ridge on the lateral side. And as you come down, you can sort of swing across, and as you come down, you can see it inserts onto your radial styloid. And this is a particular muscle that can alter or deform your distal radiuses. And it's therefore important to understand that deforming force on your distal radiuses, because sometimes we have to overcome that by releasing that when we're putting our plates on our wrist fractures. The brachioradialis is supplied by the radial nerve. We'll go on to the extensors now. So the main extensor of the elbow is your triceps. Obviously, this is 3 heads, and it's supplied by the radial nerve. So these all converge onto the triceps tendon, highlighted in yellow. And the 3 heads involve the lateral head, the long head, which inserts into the infraglenoid tubercle, and the medial head just underneath. And as you can see, when we move this model around, how closely that radial nerve sweeps underneath from the brachial plexus around the back of the posterior part of the humerus, and then comes more laterally and then anteriorly into the elbow. So this nerve, particularly when you're doing your surgical approach at the back of the humerus, is prone to injury. The common flexor origin. So these are muscles that originate from the medial epicondyle, and they are supplied by the median nerve. And you have your pronator teres, your FCR, your palmaris longus, and the FCU. And when we remove those, it kind of then reveals your more deeper flexors, your flexor digitorum superficialis and flexor digitorum profundus. Now, the important thing to note here is that all these muscles except FCU is supplied by the median nerve. So FCU is supplied by the ulnar nerve. We'll move on to the extensor origin. This is formally, also informally known as sometimes the mobile wad, which we tend to use when we're describing the anatomy around the elbow. And they tend to be 4 superficial muscles and some deep. So if we remove the brachioradialis, which is this one highlighted here, underneath it reveals a supinator. And then as the model swings round, and then brings into view your common extensor muscles, your ECRL, your extensor digitorum, and your extensor carpi ulnaris, and anconeus, which is tucked in just behind there. And these are supplied by the radial nerve. Now, it's these muscles that provide us sometimes a helpful window when approaching the distal humerus and the elbow joint with our surgical operations. So we have 2 common approaches. You've got the Kaplan approach, which is this green line here between ECRL and B and E extensor digitorum, and your Cocker approach, which is slightly more posterior, which goes between ECU and anconeus. And this provides an excellent view of your radial head, all the lateral structures of the elbow, And just to be mindful that your posterior interosseous nerve, or an important nerve we'll explain in a minute, is very close by. So just that can sometimes be get injured if we're overzealous with our retractors. So this brings us onto the radial nerve. Now the radial nerve is formed from the posterior cord of the brachial plexus and C5 to T1 levels. So the radial nerve proper enters the elbow, and then it gives off the terminal motor branch, which is called the posterior interosseous nerve. In the upper arm, you see 3 sensory nerves, and within the lower arm, you see 1 terminal sensory nerve, which is a superficial radial nerve. And therefore, this provides sensation to the back of the elbow, back of the forearm, and back of the hand. We've talked about the muscles that it supplies. And this is how you examine for a radial nerve. So we'll just go into the most common tests briefly now. So the extensor digitorum, which is your MCPJ extension, the extensor indicis, which is your little finger extension, so index finger extension, and then the extensor digiti minimi, which is your little finger extension, and your EPL. So you can see there your EPL under tension when you're opposing your thumb extension. And finally, testing for wrist extension, and that's a test for ECRL and ECRB. The superficial nerve, which is the terminal sensory branch we discussed, does travel all the way down to the forearm and can be prone to injury when we're doing our fixation operations around the wrist, and particularly KWAS of your radial styloid. There are 3 areas in which the radial nerve travels through. We won't go into these in too much detail, other than just introducing their names. So we've got the triangular interval, the lateral intermuscular septum just before the elbow, and then the radial nerve enters the forearm through the mouth of the supinator. Of the 3 nerves of the upper limb, the radial nerve is the one that has the most areas of potential entrapment. So we'll start from the top within the axilla, so you get your crutch palsy, the spiral groove, which runs in the back, obviously, which runs along the back of the humerus, and I'll show you in a second why that is. And then around the elbow joint, the posterior interosseous nerve wraps around the radial neck, and finally goes through the radial tunnel, which is almost the cubital tunnel equivalent of the ulnar nerve. So as we see, this is the radial nerve coming out the back of the humerus through the intermuscular septum here, comes in a lateral structure and then comes anteriorly. So when it penetrates the lateral intermuscular septum, is therefore prone or susceptible to traction injuries. And the radial nerve also sits so close to the bone, is also susceptible to when the distal humerus breaks. This is the posterior interosseous nerve diving into the forearm through the mouth of the supinator. So this is another area in which it can be entrapped. And finally, when you're doing your operations around the radial head and the radial neck, this is the posterior interosseous nerve running really close by. So these are areas in which the nerve can be potentially damaged. The median nerve. So this comes from the medial and lateral cord, the C5 to T1 levels. And this goes straight through past the elbow joint and terminates as both median nerve and also the anterior interosseous nerve. The median nerve proper gives rise to the palmar cutaneous branch, supplying the hand, or the palm of the hand. And we've discussed the muscles that the median nerve supplies. So the anterior forearm, the superficial and deep, and it's the deep muscles of the anterior forearm that are supplied by the anterior interosseous nerve. And the final muscles of the median nerve supplies is the thenar muscles, and that's your common loaf mnemonic. So this is how you examine for the median nerve. So we start off with the flexor digitorum profundus, which is flexion of the DIPJ, resistance of flexion of the PIPJ for flexor digitorum superficialis, abductor pollicis brevis, and this is a common test we do with our carpal tunnel syndrome because it's one of the first muscles that becomes weak. And finally, opposition of the thumb. And therefore, I'll also and the lumbricals as well, testing for extension at the proximal phalangeal joint. I'll introduce you to the idea of the AOK sign, which Kriti will go into in a bit more detail, but this is a good test to test the function of the anterior interosseous nerve and testing the deep muscles of the anterior forearm. So the median nerve and the anterior interosseous nerve are susceptible to injury or palsy in particularly supracondylar fractures. And this is because it's tethered to the distal humerus anteriorly by this ligament, the ligamentous Struthers. So when you break your distal humerus in the supracondylar fracture, the median nerve stays close to the bone and therefore is pulled as the fracture deforms. So looking at the anatomical landmarks which the median nerve goes through, it enters the forearm through the pronator teres. Common areas of entrapment remain really just at the carpal tunnel. And it's important to identify that the palmar cutaneous branch comes off proximal to the carpal tunnel. So therefore, when you have the impingement of the carpal tunnel, it therefore only affects the fingers and spares the palm of the hand. Final nerve, the ulnar nerve. So it comes off as the medial cord, CATT1, goes straight past the elbow behind the medial epicondyle. It gives off two cutaneous branches distally, and this is the dorsal palmar cutaneous branch supplying the back and the front of the palm of the hand. And we supplies the muscles, as we've mentioned previously, in the forearm, FCU, and the fourth and fifth components of flexor digitorum profundus, and the muscles of the hypothenar muscles of the little finger region, the thumb, particular attention, the fact that this is the only muscle of the thumb that is supplied by the ulnar nerve, and that's the adductor pollicis brevis, and the smaller muscles of the intrinsics of the hand, the interossei and the lumbricals. And this is how you examine for the ulnar nerve. So start off with the adductor pollicis, which is the component of your Frohman sign. And we test for dorsal interossei, resistance to finger abduction, and the palmar interossei, which is against resistance of the finger adduction. And testing for the FDP component, which is the fourth and fifth, and then finally the lumbricals of the fourth and fifth. The ulnar nerve enters the forearm through the mouth of FCU, and its areas of entrapment or common entrapment is a cubital tunnel and the Guillaume's canal, all within sort of the forearm or distal to the elbow joint. So if we again understand where the cutaneous branches come from in the forearm, we can help identify the level of the entrapment. So if you have the Guillaume's canal entrapment, the dorsal palmar cutaneous branches are spared, and therefore you only lose sensation to the digits, rather than if it was more proximal, you'd also lose sensation to the proximal part of the hand as well. So this is the surgical anatomy of the cubital tunnel. So we'll go over this very quickly. So first of all, the first part where it can get entrapped is the arcadus struthers, as the ulnar nerve then comes down and enters the cubital tunnel. This is another area in which it can be compressed. It can be finally compressed within the actual fibers or the substance of the cubital tunnel, and then the Osborne's fascia, and then the opening of FCU, or the tight bands that form the mouth of FCU. And then this is a surgical demonstration of how the ulnar nerve is fully released and decompressed, and this is the medial epicondyle exposed as the ulnar nerve runs round behind it. So on the ulnar nerve, it's probably worth mentioning about the ulnar paradox. This used to confuse me a hell of a lot, and still does. So I have to sometimes sit down and just think about it before I explain it. But essentially, if we recap, the ulnar nerve supplies the lumbricals to the fourth and fifth, and the ulnar side of FDP. The ulnar paradox is with proximal lesions, the clawing is reduced. So for example, when you have a distal lesion, you knock out the action of the lumbricals, and what you just have remaining is the unopposed flexion of the FDP of the fourth and fifth digits. So you get a fairly significant clawing. When the lesion becomes more proximal, you take out the unopposed action of FDP as well, and therefore your clawing is less. So that's ulnar paradox in a nutshell. So it's not going to be a presentation of the elbow anatomy without talking about the cubital fossa. So if we start off with demonstrating the floor of the cubital fossa, which is your brachialis, you have the ulnar nerve just behind that and behind the medial epicondyle. The lateral wall is formed by the brachioradialis. Your medial wall is formed by the pronator teres, and then you start filling the fossa with its contents. So we have the biceps tendon, and everything medial to that includes your brachial artery, and then it bifurcates into the radial and ulnar artery. And that always sits medial to your tendon, i.e. closer to the heart. And alongside that is your median nerve. The other side of the tendon forms your radial nerve. And then the roof of the cubital fossa is your aponeurosis. Elbow x-rays. So you have your AP and lateral views. And common fractures that can sometimes be missed if you don't look carefully enough tend to be the radial heads, the coronoid process, the capitellum, and your medial epicondyle. And this just here demonstrates that the capitellum sits more anterior, which articulates with the radial head, than your trochlea. A good lateral x-ray is your figure of 8 sign, which demonstrates your coronoid fossa and your Electron Fossa, and demonstrate this nice figure of 8 pattern. This then allows you to accurately draw your anterior humeral line and your radiocapitellar line, and these two lines should intersect with your capitellum and trochlea. So that is a normal lateral radiograph. It's important to identify if there's a fat pad, an anterior and a posterior one. These fat pads are normally obscured within the fossa. So when you have an effusion, such as a hemarthrosis because of a fracture, these fat pads start floating out of their fossa and therefore become more apparent with your x-ray. So that's an indirect sign that there may be an occult fracture of the elbow and may warrant further imaging and investigation. A little bit of physics now, and sometimes this can be one of the pitfalls for any limb x-ray, and that's the idea of parallax error. So when you take an x-ray, for example, of your forearm, everything that is divergent away from the middle beam, so the middle beam is your most accurate, everything else is going to be less accurate because it's divergent. So the only thing you can confidently comment on is anything within the central beam or middle of the film. So therefore, when someone presents to you a forearm x-ray and they're worried about either an elbow and a wrist, you can't confidently sort of assess or review either the elbow or the wrist accurately. So you're entitled to send these patients back for dedicated views of the elbow joint, because you're not going to get an accurate view based on just a forearm x-ray. So that's the reason why we want dedicated views of the joint concerned if there's an injury there, because of parallax error. So take-home messages. So the osseous shape influences the pattern of fractures around the elbow. And the stability is mainly defined by the bony and ligamentous structures and their integrity. Muscles crossing the elbow joint can help provide surgical windows and surgical approaches to the elbow. And finally, understanding the nervous anatomy can help you identify where the level of the lesion is, particularly understanding where those cutaneous branches come from. And finally, it's always important to get dedicated views of the elbow and not rely on other x-rays such as the forearm due to parallax error. They're just two references. I find these two references extremely helpful. That's the AO surgical reference, and also this app, which is Essential Anatomy, which is where the diagrams and the videos came from, which I would check that they will also be very interesting and sort of helpful when it comes to revising for future MRCS exams or even FRCS exams. Thank you very much.
Thank you very much, Ollie. I'll just share my screen in a minute. Can you stop sharing? Perfect. Okay. So I hope you can all hear me. Good evening, everyone. My name's Critty. I'm currently an orthopaedic registrar in the East of England, and I'm part of the BOTA committee also. And I've been tasked with the challenge of talking to you all about elbow trauma in 15 minutes. So we're going to try our best to cover some things that I feel you might see when you're on call, and hopefully these slides will help you navigate through them. So the 4 conditions that I'm going to cover for you today are supracondylar fractures, elbow dislocations, Electron fractures, and radial head fractures. So let's start off with supracondylar fractures. So obviously these injuries can occur in the elderly or the adult population, but we're going to focus predominantly on the pediatric population. And it's one of the most common fractures that you'll see in children. It most commonly occurs in those aged between 5 and 7, but can occur in toddlers or even those in their teens. It's more common in men than it is in females, and the mechanism of injury tends to be a fall on an outstretched hand. There can be two types that you need to know about. So one is the extension type that you can see here on the screen, in which you have extension of the distal fragment, and then your humerus ends up going more volar. And then the flexion type affects only about 5% or so of the fractures that you see, and you have the opposite configuration. The symptoms that the patient may present with is that they may present with pain, they may be refusing to use the elbow, they may be guarding it. And the signs that you may see is some obvious deformity, swelling, ecchymosis or bruising in the area, or there may be reduced range of movement. If you're suspecting that the patient may have a supracondylar fracture, then request some x-rays. So the classification that you need to know when it comes to supracondylar fractures is the Gartland classification. It's known to have 3 types, and more recently, there is talk about a 4th type. So type 1 is a non-displaced or undisplaced fracture. And as Ollie already mentioned to you, the line that you're looking at is the anterior humeral line. And I don't know if you can see my cursor, but you want to see that that is intersecting through the capitellum. In type 2 fractures, what happens is the posterior cortex is still intact, and therefore it hinges and displaces, usually more than 2 millimeters. And for a type 2 fracture, there doesn't tend to be any translation or any rotation. However, in a B type, you may notice that there is some rotation or translation, which may be more evident on the AP radiographs. In a type 3 fracture, type 3 Gartland supracondylar fracture, the anterior and the posterior cortex is disrupted, and therefore the fracture is off-ended. Now, when it comes to a type 4, this is when you think that there also is periosteal disruption, which means that a closed reduction is going to be extremely difficult. And this makes the fracture unstable in both flexion and as well as an extension, So what's really vital? When you're the SHO on call, it's key that you clearly document the neurovascular status of the limb. So as Ollie already mentioned, the anterior interosseous nerve navigates in such a way that it's the nerve that is most likely to be injured, particularly in an extension type supracondylar fracture. And so you test it by doing the A-OK sign. So the anterior interosseous nerve is a motor branch of the median nerve that supplies most of the flexors of the forearm, and it allows flexion at the interphalangeal joint of the thumb via flexor pollicis longus, as well as flexion at the distal interphalangeal joint of the index finger via flexor digitorum profundus. And therefore, the child is able to maintain this O sign. If the AIN is damaged for any reason through neuropraxia or injury, then they may lose this and form more of a beak sign. You will want to check sensation, which you can do by touching the median distribution of the hand, which Ollie has already shown you, but I tend to use the index finger. You can check radial nerve, and for kids, you want to keep it simple. So I ask them to do a thumbs up. And like Ollie's already mentioned, extensor pollicis longus is supplied by the radial nerve. So by doing this, you know that that's intact. I check sensation by touching over the dorsal first web space, and then I move on to the ulnar nerve. The ulnar nerve is less commonly injured in extension type supracondylar fractures, but more so in flexion type, and also can be injured post-operatively, which we will discuss further. It supplies most of the intrinsic muscles of the hand, apart from the loaf muscles, as Ollie has already mentioned. And I get patients to just crisscross their fingers, as it's something that most kids can understand and do easily. But you can also get them to spread their fingers nice and wide, and obviously check that against resistance. Always compare your findings compared to the contralateral hand. It's very important that you assess the pulses. So you need to feel the brachial pulse, as that can commonly be injured in type 3 or type 4 fractures. You need to feel the radial and the ulnar pulse. And more importantly, you need to document the perfusion of the hand. The hand has many collaterals, and therefore you need to mention if it's pink or pale, is it cold or warm, and what is the cap refill time. So moving on to the management. So most of you probably are aware of the BOTA guidelines. And if you're not, I'd recommend that you go and read the guidelines. It's basically evidence-based practice for the management of several different injuries within orthopedics, and it has a step-by-step approach. But for the basics, I'm just going to mention to you that for any fracture, you have non-operative and operative management options. So most type 1 fractures can be managed non-operatively, along with some type 2 fractures where there isn't any rotation or translation of significance. In this, you just put a above elbow back slab on the patient and keep the arm in a flexed position. You don't want to hyperflex it, but usually at about 90 degrees is suitable. Now, for closed reduction methods, you would take the patient to theatre, you would reduce the fracture, and then you would usually fire in some percutaneous K-wires or pins. You tend to do the lateral side first and tend to put in 1 to 2. Most people go for 2 pins on the lateral side. And then occasionally you will have to put one through the medial side, as obviously Ollie's already mentioned about the medial and lateral columns that you need to restore. What's important to remember, is if you have a pale pulseless hand, you need to do this immediately. And therefore, if you come across one of these, you need to escalate to your registrar ASAP, who will then escalate it to their consultant. These patients are the ones that go to theatre even overnight. And in 75% of cases, by actually reducing the fracture and fixing it, the pulse will be restored. If it is not, then it may be that you need to contact the vascular team for further exploration. But however, if you have a pink pulseless hand, rather than a pale pulseless hand, like we've already discussed, these are more of an urgent kind of case that can occasionally wait till the following morning if it is midnight, for example. Again, I would still escalate it to your seniors, but in most cases, because of the collateral supply, the patient just needs regular observations overnight. Once they're taken to theatre the following morning and the fracture is reduced, it can sometimes take 24 to 48 hours for the pulse to return. So providing that the hand still remains pink and well perfused, you can then just observe the patient. However, if at any point it goes pale, then once again, you need to take them urgently to theatre for vascular exploration. Lastly, you need to consider open reduction, and this tends to be more of a case in the type 4 fractures or those where you can't get a closed reduction or where the patient already has an open fracture. So I'm not going to go into this in much detail. The slides will be available to you, but these are the general techniques that we use to achieve closed reduction in theatre. A lot of it's to do with inline traction, flexion of the elbow, and then to put it into pronation finally to then tighten the periosteal sleeve and hold your reduction in place. We've already discussed a bit about pin configuration, and obviously if you put one through the lateral and the medial column, it's biomechanically better. However, there is a higher risk of injury to the ulnar nerve, and therefore it's really important that when you do this, many people will now make a small incision just over the medial epicondyle so that they can visualize the nerve and make sure that it's protected throughout the procedure. Some of the other urgent concerns, that you need to be aware of is the brachialis sign. So if you see excessive bruising around the cubital fossa, you need to be wary that you may have had some buttonholing through the brachialis by the proximal fragment. And again, this is something that you need to inform your senior of more urgently, and they may need to then milk the forearm to reduce that. There's also the floating elbow, and that's when you have a supracondylar fracture with a concomitant radius and ulnar fracture distally. And obviously compartment syndrome, which is a surgical emergency. So I'm not going to go through all these complications, but the key ones that you may see in an MCQ when it comes to supracondylar fractures is obviously this varus malunion, which forms a gunstock deformity. And therefore it's really important to malalign a varus fracture. Nerve palsy, which we've already discussed, the AIN the most common with the fracture type. However, from surgery itself, the ulnar nerve is most at risk. And then obviously vascular injury, although rare, can lead to a Volkmann ischemic contracture. And that's something more for an MCQ question again. Post-operative stiffness is significant. And when you see these patients in fracture clinic, you often fear that you may have to refer them to physio because they're not moving very well. But a lot of the papers and evidence suggest that that is not needed. And so a lot of these patients, once out of CAS, will gradually start moving it themselves and regain their full function in a couple of months. And you can just warn patients and their parents about that. So moving on to elbow dislocations. So it's the second most common major joint dislocation post shoulders in adults, and the most common that you'll see in children. It most commonly occurs, in the age group between 10 and 20, but can occur at any age. It accounts for 10 to 25% of all elbow injuries, and the mechanism of injury is usually a combination of axial loading, supination and external rotation, and a valgus posterolateral force, as you can kind of see in this diagram. The way that you describe it is based on the anatomical location of the olecranon in reference to the humerus. So you tend to say that it's posterior and lateral, which is the configuration you see most commonly, and that tends to be 80% or so of the dislocations that you see. So you have to look at the AP and the lateral radiographs to comment. The progression of the injury tends to go from the lateral side to the medial side, with the lateral collateral ligament failing first, and lastly, your medial collateral ligament when there is a higher degree of energy. So the symptoms again will be pain and swelling, and you have to examine the status of the skin in patients, obviously check that there's no open element to it, look for swelling. So elbows swell very quickly, and therefore it's very important that you reduce these as soon as you can. Obviously, you need to look out for compartment syndrome, the neurovascular status, and assess the wrist and shoulder, as 10 to 15% of elbow dislocations have a concomitant injury. So next, how do you classify these? So you have simple and complex dislocations of the elbow. A simple, as it states, is a dislocation with no associated fracture. And this is 50 to 60% of the dislocations that you'll see and reduce in A&E. Now, a complex dislocation is one where there is a fracture associated with it. And the most common one that you'll come across in terms of in textbooks is the terrible Triad injury. And this is when you have an elbow dislocation with the lateral ulnar collateral ligament tear, as Ollie mentioned, and you'll also have a radial head fracture, as you can see in this X-ray, hopefully, and a coronoid fracture. And you might see just above the humerus, this little tip, I don't know if you could see my cursor, but that's from the coronoid process. These are innately unstable injuries due to all the soft tissue attachments, as well as the bony structure. And often it's very hard to hold these in reduction without the need for surgical intervention. So moving on to imaging, obviously you need your basic radiographs, your AP and lateral views, as well as an oblique view to look at the periarticular surface better. However, for your complex dislocations, I would recommend getting a CT scan, as that allows you to assess the complexity of the injury and therefore determine the management. So management-wise, again, it's quite a full slide and I'll let you read it at your leisure, but the key things to remember is the closed reduction, as that's what you'll be doing as the SHO in A&E. So what you need to do in these cases is apply some inline traction, and that will improve the coronal displacement. Put the forearm into supination while you do that, and that will shift the coronoid underneath the trochlea. And then what you need to do is flex the elbow with direct pressure over the tip of the electronon. So it's best to get an assistant to help you when you're doing this. Then you want to flex the elbow and try and keep it at about 90 degrees and apply your above elbow back slab. If you can, then once you've reduced it, it is a good idea to obviously assess stability. If you've obviously got a very complex fracture, you probably don't want to do that because it will redislocate. But in these kind of less complex fractures on the X-ray, it might be worth assessing with a bit of varus and valgus stress just to see whether you think that your collateral ligaments are affected. If you think that the lateral collateral ligament is disrupted, then the configuration will be more stable by putting the arm into pronation. If you think the MCL is disrupted, then it's best to keep the forearm into supination when you put it into the back slab. Post-reduction, you obviously need radiographs, and the key is to refer these patients onto physiotherapy as elbows stiffen up and they need to be put into a splint to allow gradual range of movement. Operatively, I'm not going to go into this in much depth, but for the complex elbow fracture dislocations, or when there is persistent instability and you're requiring hyperflexion of the elbow to maintain the reduction, then these are the cases that most likely are going to need an open reduction internal fixation, or when you can't reduce it closed. Moving on to electron fractures. So electron fractures have a bimodal distribution. They can occur in the elderly because of a low energy fall, or they can be in the young generation because of a high energy impact fall. So the mechanism can be a direct blow to the electronon, and that can result in more of a comminuted fracture, or an indirect blow through a fallen and outstretched upper extremity, and that tends to result in more of a transverse or oblique fracture pattern. The symptoms will again be pain over the posterior aspect of the elbow, and it's really important that you examine the skin condition, given the fact that there isn't much soft tissue padding in that area. It's also important to look for swelling, any palpable defects, and obviously it's also important to look at the extensor mechanism of the elbow and therefore see if the patient can extend their elbow actively against some resistance, and that can influence your management options. Imaging-wise, again, you want to get your basic radiographs and AP and lateral, and CT can be useful in preoperative planning, more so for your comminuted fractures. The Mayo Classification is the classification system used for electron fractures. Again, you have type 1, 2, and 3. Type 1 is a non-displaced fracture or a minimally displaced fracture, less than 2 millimeters. Type 2 is when you have a displaced proximal fragment, but without elbow instability, and so your joint is still congruent. And this can be split into A and B, A being a non-comminuted fracture that will be more suitable for a tension band configuration, for example, and B, a more comminuted fracture that may require a plate fixation. Type 3 Mayo classified fractures are those that also have an ulnar humeral joint instability picture. And you can see that here, that there isn't some congruency between the joint. So management-wise, you can manage these again non-operatively or operatively. Non-operative management can be used in undisplaced fractures in the young and the elderly population. However, in the elderly population, even if they have a displaced fracture, you can consider non-operative management. And there was a key paper, which was a randomized control trial, looked at operative versus non-operative management in Electron fractures in those above the age of 75. It was by Duckworth et al., and it was in the Bone and Joint Journal for any of you interested. And it basically showed that the outcomes in terms of patient outcomes were not different if they were managed conservatively or they were managed operatively. So that's something to consider. Now, operatively, in more of your comminuted fractures, you're probably looking at putting a plate on, as you can see here in the bottom diagram. However, when you've got a transverse fracture with no comminution, you will consider a tension band configuration, as can be seen here. And what that does is it converts a tensile force to a compressive force. Nowadays, there is also suture fixation, which acts again in the same way as a tension band, but without the issues of metalwork. And that's something new that people are now using. Moving on to complications. As I've already mentioned, symptomatic hardware is probably one of the biggest complications given the fact that there isn't much soft tissue coverage over the elbow, particularly the olecranon. Therefore, nowadays you can get some low profile plates, particularly those that go on the lateral and medial borders of the olecranon, as opposed to the posterior border, that can help with that complication. Again, you also have the suture technique for tension band wiring, which again kind of negates the metalwork complications that we've heard of. There's stiffness, which is very apparent in elbows, and therefore physio and rehab is key for any elbow injury. And these are some of the other ones. Any articular surface which is affected is at risk of arthritis. And obviously neurovascular injury can happen anywhere within the elbow, as you've already seen by Ollie, the closeness of all the structures that run through there. And loss of extension strength is one of the key things to mention to any patients that you're consenting. So lastly, we're going to look at radial head fractures quickly. So these occur in 1.5 to 4% of all fractures that you see, and 33% of all elbow fractures. The mechanism of injury, again, surprise, surprise, is a fall on an outstretched hand, but usually the elbow is an extension with axial loading through a pronated forearm, and this results in transmission of force from the wrist to the radial head. Symptoms can be pain and tenderness along the lateral aspect of the elbow, or directly on palpation over the radial head on the volar aspect. Examination-wise, patients may have a limited range of movement, particularly on supination and pronation, and it's really important that you assess for any mechanical block. Stability-wise, you can do a various amount of tests to look again at your collateral ligaments, and also I would recommend palpating down the interosseous membrane to see for any tenderness, as this may indicate an Essex-Lopresti fracture or configuration, which I'll discuss with you on the following slide. So these injuries can be associated with other injuries, and therefore it's important that you assess these. We've already mentioned ligamentous injuries, so assessment of your lateral collateral and ulnar collateral ligaments. The Essex-Lopresti injury, which is when you have fracture of the radial head with a DRUJ dislocation. And you can also get rupture of the antebrachial interosseous membrane, and hence I mentioned the importance of palpating down that. You can have other elbow fractures, like we've said, elbow dislocations, and we've already mentioned the terrible triad, and other carpal fractures. So always assess these patients thoroughly. Imaging-wise, again, your standard AP and lateral. And as Ollie's already mentioned, the fat pad sign can be indicative of occult fractures, which is why one of the reasons why Mason type 1 fractures, which I'll talk to you about in a second, which is the basic undisplaced radial head fractures, are often missed. You can ask for a radiocapitellar view, which often they'll do anyway, which is more of an oblique view, looking at the actual radial head without the coronoid overlapping it. And a CT can also be requested for more comminuted fractures to again help with operative planning. The classification, as I've already touched on, is the Mason classification. It goes from type 1 to type 4, which is a new introduction. And again, it's from a minimally displaced fracture, which is type 1, all the way down to a comminuted fracture at type 3. And a type 4 is when it's associated with an elbow dislocation. So management-wise, again, back to the basics, non-operative and operative management. All Mason type 1 undisplaced fractures or minimally displaced fractures can be managed conservatively, and often you'll just put the patient into a broad arm sling, bring them back to clinic, and then get them onto a physio regime. You have a good result in 85 to 95% of these patients. Operatively, if you have a comminuted fracture, which is less than 3 parts, you may consider performing an open reduction internal fixation. And this is a very good option for younger patients in particular. If the patient has less than 25% of the surface area of the radial head affected, you can consider an excision of that particular part of fractured fragment. Or in more kind of low demand patients, you can consider a complete excision of the radial head. Lastly, you can also consider an arthroplasty, and this is for more comminuted fractures where there's more than 3 parts. So that's something that is worth considering, and it's pretty useful for type 3 fractures in particular, where an ORIF might not be an option. Lastly, in the pediatric population, some people will often put in a retrograde titanium nail to allow mobility of the fragment, reduction, and then to hold that in place. So these are some of the complications you need to be aware of, but the main one, again, like Ollie has already mentioned, is the posterior interosseous nerve. And that most commonly is injured on the approach that you use to access the radial head for surgery. And therefore, when you perform surgery, you tend to extend the arm at this point so that the PIN moves out of the surgical field and is less at risk of injury. Again, you've got stiffness, arthritis, and all the basic things on this slide are the things that you would want to consent the patient for. So thank you very much. I'm sorry it may have been a little bit rushed, but all the slides will be available so you can read through them in your own time. If you've got any questions, please put them in the box.
Great, thanks, Kriti and Ollie. There's been no questions throughout either of those talks. Looking at the time, I think we probably have to just quickly log off so we can let people in for the next session. Thanks everyone for attending. If I could just make sure that you all do your feedback forms, which will be available at the end of this session, and they'll be in your follow-up email that you get sent. And we'll see you all next month for what's next. We've got shoulder next. Yeah, so links for signing up for next month will be